Hello, we're back to talk more about MSDRGs and how MSDRGs are calculated. So we'll be going back and forth between the text and the slides. Please email me if you have any questions or see me during office hours. Let's have a look at MSDRGs. Okay, we have our 25 major diagnostic categories that are shown. A sample of them are shown in the table in your text. Let's have a look at those. And you can see them here, numbered 1 through 25, diseases, disorders of the nervous system, diseases, disorders of the eye, ear, big one here, circulatory system, respiratory, digestive, and so on. This is in table 5.2 in your text. From there, we determine whether it's a surgical or medical MSDRG. And then these are subdivided. And the structure of MSDRG, which is a Medicare Severity Diagnosis-related group, is based on the principal diagnosis or principal procedures, right? So we can have up to 25, and we figure in other factors as well, gender, age, and so on, as you can see here. And the idea is each of these DRGs has carve-outs for comorbidities and complications, which we'll talk about a little bit and get into some finer details on this. So we've assigned our major diagnostic category, if you will. We do some pre-diagnostic category work. And we look at the length of stay, and this gets back into health statistics. We have an arithmetic length of stay, which is basically the average that we all know of, where we sum all the lengths of stay and divide it by the number of cases. What we do with the geometric mean, which is in many ways a better way of looking at the length of stay, is we take the nth root in a series of the nth length of stay. So we can see the difference here in this section in your text that I'd like you to pay special attention to. And you can see here in example 5.1, the arithmetic versus the geometric mean length of stay. This is what we looked at in HIM 200, where we just add up the observations, divide by the number of observations, but note that we have an outlier of 30. Everything else is pretty closely grouped. So that skews this to be artificially higher. With the geometric mean length of stay, we multiply each of these values and then take the fifth root, if you will, of this value. And it gives us a more true picture of what's going on. So the GMLOS is not influenced by the 30-day length of stay outlier. And then we have the relative weight, which measures the resource intensity for the admissions, and the code range. And this is where the codes drive the MSDRG assignment. You can see here, for some of these heart failure codes, they fall into MSDRG 293 for fiscal year 218. And note that the geometric mean length of stay is 2.3. The average, the arithmetic mean length of stay is 2.8, a little bit higher, relative weight of 0.655. And here are our principal diagnoses. If a patient is admitted with this principal diagnoses, which is, as we know from coding, the reason for admission after study, then it would most likely fall into 293. I say most likely because there are always some exceptions, and we'll get into that in a little bit. The severity of illness component basically refers to how sick the patient is, the extent of the physiological decompensation or loss of function, if you will. And the MSDRGs use these secondary conditions to establish severity of illness. And this is where complications and comorbidities come in. Major comorbidities or complications are, you can think of as kind of adding on to these. And your text gives you some examples of this. So let's have a look. They give you a nice example of this in figure 5.4. Example 1 is an MSDRG which doesn't have any complication, comorbidity, or major complication or comorbidity. Example 2, we have a complication, comorbidity, major complication, comorbidity. So you can think of the patient is sicker, therefore is in need of more resources, more tests, more nursing care, all of that. So, and then with 3, we have the major comorbidity complication. We have a comorbidity complication, in other words, extensive severity of illness, and that's kind of driving those things. So basically, the hospital is going to be reimbursed for patients with that. This figure 5.5 is talking about these going from left to right. So we have a procedure, right? And falls into major diagnosis category 6, diseases and disorders of the digestive system. That's the pre-work. If there are major complications and comorbidities, this is what's going to change the relative weight. Note how it gets higher when there is, and the MSDRG number changes. So of course, we just kind of walk through that example. That's also in your book. We do the pre-MDC assignment, major diagnostic category, the MDC assignment, determine whether it's surgical or medical, and then we refine it with the major comorbidity complications or the comorbidity and complications. And again, we took a look at this in table 5.4 in your text. And they give example 5.2 in your textbook as well, right? Again, if we're doing a pancreas transplant, it can be performed for a number of different clinical reasons. And the diagnoses that warrant a pancreas transplant are found in multiple major diagnostic categories, but there's only one MSDRG for all pancreas transplants, regardless of what the principal diagnosis is. So again, this is one of the reasons we want to parse out what is surgical and what is medical. And again, once we determine the major diagnostic category, we want to look at the principal diagnosis. And this goes back to coding. It's established after study to be chiefly responsible for occasioning the admission. In other words, what's the reason that the patient was admitted? And the major diagnostic category of this principal diagnosis for a non-surgical patient is used for DRG assignment. And so here's one from example 5.3. And let's walk through this. Patient A comes in, is treated for pneumonia caused by strep, group A. It's going to go to major diagnostic category 04, diseases of the respiratory system. Let's take a look at that. So you may find it useful to walk yourself through these. And patient A comes in, they're treated for pneumonia caused by strep. It is coded. So the major diagnostic category is going to be MDC4, disease disorder of the respiratory system, and the principal diagnosis would be pneumonia caused by strep group A. You may want to walk through some of the other examples that are in that same section of the text and see if this makes sense. You'll also hear talk about the complication comorbidity and major complication comorbidity exclusion list. And these are principal diagnoses that take away the refining power for the comorbidity complication or the major comorbidity complication code. So, in other words, the principal diagnosis usually is very closely related to the comorbidity or major complications. So, it's not expected to make it more resource intensive. So, it doesn't move the admission to a higher weighted MSDRG. So, this is where health information and coding comes in. If we have inaccurate, invalid coding and abstracting, we have an invalid principal diagnosis, we can't assign it to a MSDRG, right? Or should say that it's not specific enough, right? If we don't have the right codes, could be ungroupable, so therefore we can't assign it to an MSDRG. CMS does allow for some carve-outs for this, kind of with the same logic of complication comorbidities, major complication comorbidities. We have high cost outliers. So in other words, for certain cases, the charges are adjusted to the cost. Some cases exceed the threshold amount admitted for that fiscal year, and the additional payment amount is equal to 80% of that difference for the stay and the DRG payment and threshold. That's the way if we have one outlier, it doesn't financially cripple the hospital. There are also a lot of carve-outs for new services and technologies, anything from clinical trials, all these other different types of things. We want to ensure that work still goes on in this area. So CMS allows for new innovative services and technology to be provided for Medicare beneficiaries. And we get the full DRG payment plus up to 50% of the new cost of technology and services. And there are all kinds of regulations with the FDA and others about usual cost and all these other things that come into play here. But suffice to say, if you have an approved new and innovative service technology that's been approved by the feds, they will allow a full DRG payment plus up to 50% of cost of the technology or the service. And here's an example. Jakafi, which I won't attempt to say its real name, it's used to treat adults with polycythemia vera who have already taken hydroxyurea and it didn't work well enough or they couldn't tolerate it. And it's a treatment that medication, if you will, that's used to keep the production of blood cells under control. They have a maximum approved payment of $3,977.06. And of course, there's a PCS code that we probably will introduce in 271. And it's the introduction of this medication through the mouth and pharynx, external approach, new technology group 5, used to activate the add-on payment. So if you don't have that PCS code, the hospital will not receive the add-on payment. And that's all I have for you. Come back and we'll finish up our lecture on inpatient prospective payment systems and MSDRGs.